My name is Nika, and I'm with the Momentum Integrated Health Resilience team. I'm going to get us started today. We're very excited to present this session featuring Momentum's Country and Global Leadership Project, together representing 2 of 6 projects within USAID's Momentum Suite of Awards. For today's session, we will begin with brief introductions and an overview of child health and pediatric death audits, or PDA. Then we'll have presenters from MIHR describe the process of an implementation of PDA in their respective regions, and conclude with a presentation from MCGL on preliminary findings from PDA implementation in developing settings. There will be opportunity for Q&A at the end. Our panelists today for today's session include Anna-Claire Ngabonzima, a public health and health economist with over 15 years of experience in designing and implementing public health interventions focused on maternal, neonatal, and child health from subnational and national to international levels. He's the child health lead for MIHR, providing overall strategic leadership to the child health team. Dr. Edu Buluntu is a doctor specialized in epidemiology and epidemiological surveillance, a Master of Research in Maternal and Child Health, and PhD candidate in Maternal and Child Health. He has 20 years of clinical and humanitarian experience and is the DCOP and MCH Technical Advisor for MIHR and DRC. Dr. Demba Traore is a physician specializing in public health and infectious diseases with 22 years of professional practice, including 15 years in INGOs and at the Global Fund as Permanent Secretary of CCM Mali. He also worked at UNFPA Mali as a national consultant on GBV and supported development of the investment case for achieving zero preventable maternal death, zero unmet need for family planning, and zero gender-based violence. Dr. Traore is the technical director in reproductive health.
Nika, you're going super fast. Remember this, that French has twice as many words as English. So you need to pace yourself a little bit with translation.
Okay, thank you for the note. Dr. Traore is the technical director in reproductive health and family planning lead for MIHR in Mali. Nicholas Sasa has his MPH and an MBA in healthcare administration and a diploma in clinical medicine. He has more than 15 years experience serving in both humanitarian and development health projects at various capacities in Sudan and South Sudan, and is fluent in English, French, and Arabic. He currently serves as the child health advisor for MIHR in South Sudan. Dr. Abdulaziz Imam is a Nigerian-trained pediatrician currently with the University of Oxford for a PhD focused on the nursing workforce and newborn care quality in under-resourced neonatal units. His professional career spans over 15 years of working in various developing country clinical and research contexts, including leading research teams and helping to set up vaccine studies and clinical trials at the Medical Research Council unit in the Gambia. Finally, Dr. John Barrazzo is the Child Health Director for MCGL. Previously, he was Senior Health Specialist for Maternal, Newborn, and Child Health at the World Bank hosted global financing facility for women, children, and adolescents. And prior to that, had a long career at USAID, where he led environmental health, water supply, and sanitation, and maternal and child health programs for over 25 years. Thank you all so much for joining today, and I'm going to pass it off to my colleague Anna-Claire to get us started.
Anna-Claire, you need to open your mic.
Thank you so much, Nika, for the quick background and the introductions. Once again, thank you for joining us today. Through this first session, I will provide you with a background on child mortality and then a rationale of pediatric death audit rollout. Starting with the background on child mortality, substantial global progress has been made in reducing the number of deaths in children less than 5 years of age since the 1990s, with the global under 5 mortality rate having declined around 60% between now and 1990. So, however, it is important to keep in mind that the pace of decline was uneven, not only across countries, but also within countries. So despite this uneven global decline, improving child survival remains a matter of urgent concern, as around 5 million under 5 deaths still occur every year. This is around 14,000 deaths a day, and this is more than yeah, it's more than 13,000 a day, around 13,800. And a large proportion of these deaths occur in sub-Saharan Africa. Sadly, a large proportion of deaths are mostly from preventable causes. And children in sub-Saharan Africa are more than 14 times more likely to die before the age of 5 compared to children in developed countries. So many under 5 deaths that could be prevented continue to occur because of poor quality of care, particularly in low resource and fragile settings. Next slide. Continuing with the overview on child mortality, but at the same time tackling on the rationale of PDA rollout, I want you to look at this figure, this paragraph, this graph. So this graph is taken from the Child Survival Action of the Child Health Task Force, and it captures 54 countries which are off track to meet Sustainable Development Goal 3.2.1 of attaining under 5 mortality target of 25 or fewer deaths per 1,000 live births. And it highlights that 43 of these countries are in Africa. But the important additional message here is that in most of those off-track countries, a significant proportion of children of child death occur in the period of 1 month to 59 months. That's our postneonatal death. That's the first point where PDA comes in first. So by looking at the first 15 countries, 13 are either in the West or Central Africa. In addition, some countries on the top, the postneonatal mortality account for more than 60% of under 5 mortality. So therefore, much has to be done in this age group if we want to accelerate the progress towards the attainment of SDGs. Next slide. Now, on this slide now, there are two messages. Number one is that to further reduce the number of under 5 deaths, the quality of child health care and factors that contribute to death should be examined. This is because understanding the circumstances and factors that lead to a child death can prevent other death, poor health outcomes, and all disabilities. So auditing child death is important for improving the quality of care in health facilities, and therefore PDA is a quality of care tool. I want to emphasize on this, that PDA should be regarded as a quality of care tool, because understanding the factors behind under 5 death may be essential for identifying life-saving public health interventions and reforms at all levels, including subnational level, including health facilities, then national level, regional level, and international levels. Next slide, please. Now, review and response to maternal and perinatal death is functioning in one way or another in many low middle-income countries, but child deaths are rarely audited. And I want to here focus on the fact that there was no guidance for pediatric death audit until 2018, when WHO published PDA guideline in English, and then the one in French in 2021. So what about our organizations? So our organization, first of all, are USAID Global Flagship Projects, with Momentum Integrated Health Resilience being designed to strengthen quality maternal, newborn, and child health, voluntary family planning and reproductive health care, and service delivery in fragile settings. And the Momentum country and global leadership aiming to support country partnership to apply evidence and best practices to improve maternal, newborn, and child health. So both organizations recognize that PDA, pediatric death audit, is an essential quality improvement intervention or quality improvement tool. Next slide. With this slide, I really suggest to come back on the PDA cycle and just emphasize on the fact that the pediatric death audit is a cycle. We use the same cycle as the one of MPDSR, and this cycle has 6 steps, and all these 6 steps are more important and they have to be taken into account. We can't stop at any step and say we are doing the PDA. So if we don't go up to step number 5, the step number 5, implement action plans and make changes. In this case, we can't really save any life. Next slide. Now, with this overview in the rationale of pediatric death audit, with this overview in the rationale of PDA rollout, I'd like to thank you, first of all, for your kind attention, and then turn the floor over to Dr. Demba Traore, who is going to talk about PDA rollout in Mali. Dr. Demba, the floor is yours. Thank you.
Merci, Dr. Anaclet, pour ce rappel de revue générale. J'ai le plaisir de partager au nom de l'équipe du Mali l'expérience du Mali en matière de
Thank you very much. I have the pleasure to share with you this
Je
presentation.
tiens à me remercier l'ensemble de l'auditoire pour leur participation et nous resterons à
for your
l'écoute
participation.
pour les questions de
Thank you very
clarification.
much for the participation. We are here.
Juste un rappel, il est important de rappeler que les
It's
décès
very
maternels
important to remind all
constituent un vrai drame social dans nos pays
that
et
this
particulièrement
is a social problem, a social drama. It's
en
a
matière de
tragedy.
santé publique. Nos indicateurs restent très
It's
élevés
a
malgré le
tragedy
progrès
for
que nous avons
parents,
eu durant
for all
ces
the
dernières
members
années.
of the family and the community and health agents. In spite of all these improvements, it's still a major national
L'audit
problem.
des décès, l'analyse du déroulement de la
We
survie
need
des
to
décès
analyze
permet
the
d'identifier
whole
quand même les
context
facteurs modifiants qui ont
and
contribué au décès
deployment
et pour vraiment contribuer à améliorer la
for
qualité des soins,
development of this
mais aussi
situation to
intervenir sur les
improve
facteurs non
quality of
médicaux
care
qui ont
and
contribué au décès.
interventions.
Voilà un tableau qui résume un peu près les
It's
indicateurs de nos pays.
here we can see this board the metrics of mortality.
Donc, pour faire face à cette problématique de décès maternel au Mali, le Mali a adhéré à des engagements
Here in Mali, we have great commitments to respect of the SDG 3.2 to eliminate
mais aussi le Mali a
deaths
élaboré des stratégies nationales.
that are younger than 5 years of age, but there's a national strategy
la mise en place d'une stratégie de surveillance des
to implement strategies, to set in motion strategies, thanks to a ministerial decree which was
En
set
termes de
in
chronologie,
March
il est important de
17.
rappeler ces 15
This is the
dernières années, le Mali a adhéré à
chronology
ce
of
processus.
the
Depuis
introduction
2006,
of the
mais
process
je
in
pense que la
Mali
date la plus importante que nous
2006.
devons retenir,
We did
c'est
the TOT, training
l'élaboration
of the
de
trainers,
l'intégration des décès
about
dans la
audits, about
surveillance
PDAs
épidémiologique de
in
Mali,
Dakar,
à partir de
selection of 3
2016.
sites for tests for
Et en 2018, le pays a
PDA,
pour la
training
première
of
fois cette
trainers
étude
at the
nationale
national level
des études
for
évaluées sur la surveillance
PDA,
des décès.
introduction of the surveillance concepts and the guide
Et
on
ces outils
surveillance
ont été révisés
integrated
pour la première fois en
on
2022.
SDMPR,
Mais malheureusement,
training of the
dans
regions.
cette révision, le
In
Mali n'a
this
pas
review,
intégré les recommandations de l'OMS
Mali
qui
didn't
intégraient les décès
have
pédiatriques dans le système de surveillance des décès maternels et périnatals.
Mali
Donc, c'est à ce niveau que le projet MIR
tried to
a intervenu
integrate
auprès du ministère
prenatal
pour prendre en
care.
compte les
That's where
décès
MIR
pédiatriques dans le
didn't
système de surveillance des
implement
décès.
fully the recommendations. That's what MIR.
Donc, durant ce processus d'introduction, elle a été faite en 9 étapes. Donc, les 9 étapes, c'est vraiment... OK. Donc, c'est le processus de mise en place de
The
ces
process of the set in motion of these audits, the methodology that we use is the
qui avait
following.
commencé
First,
en mars
we begin in March
par un plaidoyer auprès du ministère
2022
pour la révision des
with the ministry for the
intégrales des décès
review of
pédiatriques.
these deaths, for these
Après cette
pediatric deaths.
acceptation,
Then there's a
le projet a
workshop on
appuyé
national
sur
adaptations
l'adaptation
of
des outils,
national directives,
mais aussi leur
and was
validation au
supported
niveau
by
national.
SDMPR Then there is experience on the pilots
Finalement,
on Gao
il y a eu l'expérience
and
pilote dans les régions de
TVT.
Gao, les zones d'intervention du projet Gao.
Then there was a workshop for validation of national directives on April.
Voilà.
Then
L'autre
was
étape
the
importante, c'est après la
digitalization of
validation des
audits,
outils, nous avons appuyé le ministère pour la digitalisation
making
des
a
outils de collecte de
clinical
données
audit. Then we
et puis
did
le paramétrage dans les tablettes.
training of committees, a training of committees to audit clinics on
Et
the approach.
en amont de la
And,
validation, il a
and
procédé à la
then the
dissémination de ces documents au niveau des
national
zones
determination
d'intervention.
of directives on SDMPR, TB,
Donc, ces
TBT,
outils
and GAO.
paramétrés
And
digitalisés ont été
finally, a
testés
virtual
et
test
que dans les prochains mois à venir,
on,
nous allons commencer l'opérationnalisation des outils digitalisés dans le système de collecte de données sur le terrain.
quantitative tools and number tools and figure tools, doing virtual tools of all these numerical tools or statistical tools.
En termes
and
d'expérience,
clinical
en
audits.
tant qu'expérience de pilote dans nos zones d'intervention du projet,
After the
notamment
pilot's experience, with our experience in the pilots, these were the results. Our intervention centers improved. These are the
le système a
improvements
enregistré 71 décès pédiatriques,
from January to June
dont 8 seulement ont
2023.
été
As
audités,
you all can see, there
soit
was significant
11%.
improvements.
C'est vrai
Look
que
at,
ce taux
look
est
at
très
the
faible,
districts,
mais il faut
Tombouctou,
tenir
Gao,
compte qu'avant
look at
l'intervention du
the
projet,
registered
il n'y avait aucun
pediatric
système de
deaths
notification ou
and
d'audit
the
des décès.
audited case. And look at the
Donc, le
percentages.
processus est à son début et ça nécessite
28
vraiment l'engagement
audited
et l'implication de
cases,
tous les acteurs. Et nous comptons
43 in
sur
Gao, audited
ce
cases,
tapis
12%.
pour l'année 2024 pour
These
encore
are the
accélérer afin de
results
réduire les décès
during
pédiatriques.
this period on the screen. Next slide.
Donc,
Very
durant
good.
le processus de mise en œuvre, nous
Difficulties
avons
or
eu 3
challenges
difficultés
during
majeures.
this the implementation. We have different problems.
La première
these are
difficulté, c'est le
most
faible
relevant
niveau
ones.
d'engagement des acteurs
A
au
lack
niveau
or a weak
la
level of
conduite des
engagements by agents
jusqu'à
for
présent, il y
clinical
a une
audits.
certaine
There's lack of
perception, une certaine
commitment, lack of
réticence
engagement.
sur l'importance de l'audit
Also
dans
very
l'amélioration
weak
de
level
la
of
qualité des soins.
monitoring or follow-up to apply
Certains
the
pensent que
validated
une approche
directives or
d'incrimination
guidelines.
ou
So there is a lack or weak
une crainte
coordination
d'appréhension sur
for the
l'audit. Donc,
response
du fait qu'ils
plan.
ne sont pas très
The
engagés
response
dans la
plan.
conduite de
So
l'audit selon les
sometimes
travaux.
people didn't feel that these were important. These audits were important, and that's why
L'autre
they didn't fully
difficulté,
commit.
c'est par rapport aux
So
services
these
techniques
were some of the
en
biggest
charge de la
challenges we
surveillance qui ne
faced.
sont pas très engagés dans le suivi,
And we are not
la mise en œuvre des
ready.
directives
We
nationales
are
à tous les niveaux.
so technically they're not ready to follow up on this. So there's a low level of implementation, low level of
Troisième
continuity,
difficulté
and also the
qui est
extension
encore
or
pertinente, c'est le
expansion of the
problème de
utilization
suivi de la
of
coordination dans les plans
numeric
de report.
tools
Et comme vous le
because of the
savez,
above.
il est bien de faire l'audit, mais si les plans de report ne sont pas
As
exécutés,
you
il est
know,
difficile
these audits can be made, but if response
qualité des
times are not
données
well
dans les
coordinated
indicateurs
and not
des
timely, we cannot have
pédiatriques.
a good response. And therefore, it reinforces the conviction that it's
Et
purely
en termes de
academic
prochaines étapes, actuellement, il nous reste 4 étapes clés.
and
que
then
nous
at the
comptons
next
appuyer.
stage, and we have four key stages following up.
Nous allons appuyer, nous allons faire le
We are going
ministère
to
pour faire la
we're
signe
going to go
officielle de
ahead and do these
directive.
four remaining steps.
Nous allons continuer à
With
appuyer le
the
système de
next
surveillance
slide,
pour la notification
we're
des
going to
décès
sign an
pédiatriques,
official letter for the notification of pediatric deaths in the
suivi de la
system, the health
formation des
system,
comités d'audit sur les outils digitalisés
the health
et nous
information
souhaitons
system, and
l'expansion
make
des
the
outils digitalisés sur
notification of
l'ensemble du
these
territoire malien
and
avec l'appui des autres partenaires. Voilà en gros ce que je voulais partager cette expérience. C'est l'occasion pour moi de
this
remercier
was
l'ensemble des
slowly,
de
this is
sièges
what I wanted
qui
to
nous
share
ont
with
appuyés dans ce
you,
processus.
and the opportunity to thank you
Donc,
all that accompanied me and helped me
je passe la parole
with
à
this
mon
effort.
collègue
Thank you very
du
much.
Soudan pour la
I'm going to
suite de
give
la
the
présentation
mic
au niveau
to
des
my
mesures.
colleague from
Et
South
les questions sont
Sudan,
les bienvenues.
Nicholas Sassa, our child health advisor. And at the end of this intervention, I can answer your questions later in the Q&A.
Thank
Mr.
you.
Sassa.
I hope everyone can hear me.
Dr. Sasa, yes, go ahead. We could hear you. Dr. Sasa, you need to activate your mic.
Yes, yes. Yeah, I just want to make sure. I just want to make sure I can be heard because I'm having issue with my internet. Okay.
No,
Thank
you're
you so
fine.
much, colleagues.
You're fine.
Okay. Thank you, colleagues. My pleasure to share PDA experience in South Sudan. Move on to the next slide, please.
You were just silent. You were silent just now. No, we're not listening anything at all, Dr. Sasa. We lost your sound completely. There's no sound, sir. Hello?
Let's go ahead and we can come back to Nicholas. So
Okay.
we'll
We
go with our
switch to
next
another one.
We'll just move forward to the next presentation and come back
Okay.
to Nicholas.
Okay, so we move forward the slides quickly with you.
Yes.
Camilo, you can follow her all the way to the next one, to Dr. Edo, and
Yes.
then we can give the floor to Edo, and then we'll get back to Mr. Sasa. Voilà, vous pouvez commencer.
Merci beaucoup. C'est Dr. Edo Baluntu, conseiller technique en santé maternelle néonatale.
Well, thank you. Thank you very much. The project, I'm going to talk about the review of pediatric breaks in RDC. It's a resilience project. It's a resilience project. Go to the next slide, please. Next one. Yes, this one. So it is a resilience project in essence that was set in motion in the province, in the North Province, North Kivu. This is one of the most important, well, it's the one of the mostly affected, most affected provinces in RDC. In almost all aspects of maternal and neonatal and child health, it's highly affected. Family planning, mostly because of family planning. Family planning is key here, and MIR addresses and approaches all these aspects in this province. So it's a high impact area for us, generally. In these zones that you can see in the screen is tiny, but you can see the ones in green. Watch the ones in green, up and down. You can see those. These are 34 in total. The 10, the ones that in yellow, MIR gives a partial institutional package to impact this specific region. Some KPIs, some health metrics. So some health metrics in the North Kivu. North Kivu, we can say the total population of RDC is more than 100 million inhabitants, with an intensity of 45 per square kilometers. 4 doctors per 10,000 inhabitants and 11 nurses. And the mortality rate is 846 per 100,000 born live, almost 1 doctor for 10,000 inhabitants. It's tiny. And child mortality in DRC is 85 per 1,000 live borns. Next. So child mortality in RDC is decreasing in the last few years. It could be better, but we talk about the health of children. We can take a look in blue, the projection of the decrease of child deaths, and in green we have the necessary progression that we should achieve to achieve SDGs, global development objectives, sustainable global objectives. the country had an important reduction, decrease of 148 per 1,000 live borns. These were 42 to 28 newborns for newborns. So with the objectives, with SDGs, if we follow progressing in the reduction of this rate of 6% vis-a-vis these objectives, from as well as for newborn or neonatal borns, if we continue decreasing this rate from 1, we will get to 25 deaths for 1,000 live borns in 2030 per 1,000 born. So we would reach that rate. The main cause of these deaths are premature diarrhea and other illnesses. If these interventions of death reductions are really necessary to reduce these pediatric deaths, will allow us to manage quality of care, knowing the factors that contribute to these deaths and identifying the factors of planning and information and reinforcing this proactively in a framework that we call supervision committee RDPs. Our approach for implementation of RDPs in DRC, the focus of these, this is currently in a pilot phase, and with the pilot, he has the help and support of MIR, MIHR, and other programs. It is a comprehensive approach of focusing on health zones at a local scales, going to the provinces and going further to the national level in a gradual, scalable approach. And we want to go to other provinces and impact other provinces in this gradual, scalable approach. Next slide, please. Our approach of our implementation of RDP in RDC. The process began in March 2023, and we are in the preparation phase of that training of the trainer, of training the partners in those health zones. Here, could you please go to the next slide? We've put in place tools and notification and reporting forms and planning facilitators of the TOT approach, the trainer of the trainers approach. Could you please go to the next slide? And once we've trained these, we would have identified the. Camilo, you have to go to the next slide, please. Next slide.
Encore, avancez encore l'autre slide. Next slide, please. Nous pensons une fois que nous avons formé les prestataires.
Next, once we've trained these vendors in these health zones, we would go to establish the pilot zones with this focus. That's how we've set in motion a committee for trained service providers that will use these tools, and we will adapt these tools based on the results of these pilots, and we're going to digitalize all these tools, make them pervasively available, and to implement best practices learned in the pilots, and use this focus in other provincial committees to be able to permeate these practices and have a better response. Go to the next slide, please. Great. These are the stages, the next stages. Next.
Les suivants slides.
Next.
Slides, s'il vous plaît.
Next. Yes. This one. This one is okay.
S'il faut parler des défis,
So if we talk about challenges, on the left, challenges. With the budget restrictions, we have trained a limited number of vendors, a limited number of service providers, and there's a lack of local skill sets and competencies and capability for implementing the tools. We were accompanied by DMPR and the committees that helped us in the creation and the validation of these tools. And we think that the appropriation and sense of ownership of these pediatric deaths and the experience of the members of this committee can help greatly to gain more engagement and guarantee implementation. And with the existing committee, this could be much more effective and will allow the comparison of these perinatal deaths would be approached in a much smarter way. Thank you very much. Thank you very much. At the end, we will have some Q&A. We can go to the next presentation. Nika, are we going to go back to Sasa or to the next one?
Yes, we'll be back to Nicholas's slides. Please. Here's
Okay. Nicholas, can you test your mic again, please?
Sure.
Good. We've got you.
Whenever you're ready, Nicholas. Over to you.
Yes, I'm ready. I'm ready, please. The screen is not moving.
We're on child health overview.
Nicholas, are you speaking? We're on child health overview.
Yeah. For some reason, everything is in Spanish now. But anyways, I can go through this.
You can.
Thank you.
The screen you can see. You can go up to the view screen, view options, and select Nika, and that way you can see the English presentation. Go to the top, view options, see, and you can go down and see Nika, and you'll see the slide deck in English. The slide deck in English.
The view. It's not moving.
View options.
Up in view options, and then you can see, you click on that,
okay.
those share screens, Nika, choose Nika Nazari, and there you'll see the English deck. Okay.
View screen is not giving me anything. Speaker.
So you don't see the screen.
I think I can follow it even if it is in Spanish. I think I know this. So let's just move on to save time.
Okay.
Yes, my pleasure to share with you PD experience for South Sudan. Before I get into the mortality figures we can see on the screen, I want to share with you that despite the challenges in South Sudan, the Ministry of Health has a well-structured health systems in terms of the organogram from the national, subnational, county, and community level. So all these systems are there. And also the Ministry of Health has a well-structured health policy and the strategies for each department within the ministry. However, the implementation of those policies and strategies are where they're having challenges. The impact can be seen in health services for children under the age of 5. As you can see on the screen, infant mortality stands at 63 per 1,000, and under 5 at 97. One of the issues also you can notice is that immunization has badly declined from 71 in 2012 to only 26% in 2016.
Nicholas, are you still there?
I'm there, but the screen is not moving.
On major causes of mortality, the next slide.
Yes, the major cause of mortality basically for under 5. Top on the list is neonatal causes, pneumonia, diarrhea, malaria, and measles. Next slide, please. And also, acute malnutrition has added another burden to the health system in South Sudan. And the key drivers of acute malnutrition are related to food insecurity, inadequate feeding practices, disease, and poor hygiene. Next slide, please. Now, with support from MIHR and WHO, PDA was introduced as an approach to address quality of health services for children here in South Sudan last year, around August to September. Next slide, please. Yes, now, the steps, go back, please.
We're on the steps slide. I know it's not loading as quickly for you. Nicholas,
Yes.
can you? Okay.
Yeah, okay. Yeah, basically the initiation for this discussion around PDA in South Sudan, we started it at the Child Health Technical Working Group meetings. And then we discussed with WHO and our colleagues from UNICEF. And then right after that, WHO picked interest. And then they organized a TOT training that comprised MPDSR and PDA as well for 3 days. And then after that discussion, we had a series of meetings, and then the site for piloting PDA in South Sudan was selected, and that's the Sabah Children's Hospital. And then once the site was selected, there was a formation of the committee to oversee this PDA activities. And once that was done, with support from WHO and of course from MIHR, so an orientation was conducted for the staff at the facility, basically to go through the processes and explain to them the concept of PDA. And now, once that was done, then we looked at the WHO generic tools for PDA. So we looked at all components for the the different forms needed for the context of South Sudan. Slide is not. I think the slide is, there we go. Yeah, here we look at the first audit was conducted, and this data is just a preliminary data showing us the kind of information we collect. We look at the overall admission, and then from that, we look at the mortality, and then we segregate them by male and female. So here, this data is not subject to any interpretation of this stage because we are piloting and there's inputs and revisions and so on. So this is just showing you what we are doing currently in South Sudan and how we are looking at that. Next slide, please. Yeah, and also remember this issue of PDA, it comes with some issues. People have a reservation thinking that there is some blames. This unit did wrong and so on. So we don't, we give anonymous letters for each unit within the hospital, A, B, C, D, as you can see on the screen. And then we look at the death per each unit. all the way, including the stabilization center, which we are going to talk about in the next slide. Next slide, please. Now, this stabilization unit was picked because our initial review indicate that the majority of death is occurring at the stabilization center. So we wanted to really look deeper and see what is happening in the stabilization center. Again, this reflecting the month of May and June. We look at the total admission and then the number of deaths by male and female. And then we look at the percentages. It's very high, beyond acceptable rate. Next slide, please. Now, after the review of all this information that we just looked at, so we look at the modifiable factors. One of which is the triage. We have so far streamlined the triage at the entry point all the way through to the inpatient. And also we look at each medical officer unit, if they are well trained, if they are oriented on PDA. And also we look at the stabilization center, because the issue is that there is a lot of funding given for stabilization center for nutrition program, and yet we are getting big numbers coming in there on monthly basis. So we look at the staffing, we look at the parents and the caretakers and the overall operation within the stabilization center. And we do conduct continuous medical education for the nurses and the staff at the health facility, as well as for the interns. And also we make sure that there is adequate supervision by the medical officers for all the cadres, like the nurses and then the interns. Next slide, please. Now, this is actual picture showing the actual audit in action. So what so far we have really succeeded in is that there is enough support from the hospital administration for this PDA. And also the South Sudan Pediatric Association, they're also very supportive of PDA activities. And there were usual issues associated with PDA, so it's not an issue with South Sudan anymore. Next slide, please. Next slide, please.
We're on the challenges slide, Nicholas.
Okay. Now, I guess it's Spanish, but showing the the issue of the challenges. There are some issues with the structure of the Ministry of Health. So child health unit is still not really established at the Ministry of Health. So therefore, issue to do with leadership to guide the activities for child health is a challenge so far. And there is ongoing discussion to address it with the Director General at the Ministry of Health. And also there are some USAID restrictions in terms of this trafficking in person, the tips. South Sudan is designated as one of those countries under sanction on the USAID because of its involvement in child soldiers and some other violations relating to children. So funding for child activities are prohibited from the government. So they don't want us to engage the government that much in terms of financial support or anything like that. So therefore, realizing that this is what the restrictions is in place for, so we are having challenges with the government officials at the Ministry of Health in terms of approving necessary documents for child health. So this, issue is becoming a very serious issue for us to even call them for a meeting, because at times they just turn down the meeting. They don't want to come for a meeting, and we cannot operate without the government officials. So that's why I put this in here. And lastly, on the bottom is the issue of staff turnover. Medical officers who are really committed to working with us on this PDA, but they're not well paid by the government. Some of them are not even the government payroll. They were on the project and the project is out. So they can go anytime their way to find where they can get a better job. So when this happens, it's a big blow for us, because the people we started this program with, and they are no longer there, to get new people to replace
Nicholas, can you see the slide? Nicholas, are you still there? You might have lost
I believe we
connection.
lost him. I believe we
Yeah.
lost him, Nika.
Okay,
Ne-
let's,
Nika,
yes.
would you
back.
like me to? Okay. Okay.
I'm back, please.
Okay, we're on your last slide, Nicholas.
The last one is, I think, I was talking about the digitized PDA.
Yes, go
Yeah.
ahead.
So basically, the digitized PDA, we thought it's a really good practice, since mostly everything is moving digital, to have PDA digitized for the notification form and the registration form. So we looked at the WHO generic forms, and then we had the meeting with the pediatricians and the medical officers here in Juba. Anaclet actually came to support the activities for 2 days, to revise them and to contextualize them to the South Sudan context. So the process is completed. So next for us is to do some orientation on the use of tablets, which are already procured, and start the process of notification using the tablet, because it makes it easier for the officers to use those tools as digital. And the benefit basically is for keeping record of this, because paper-based can get lost anytime. So I think with the digital, we can have access to this anywhere, with the NGO, even with the Ministry of Health. So this is the next step we are moving with this PDA. Next slide, please.
Thank you so much, Nicholas. Thank you for your presentation. I'm sorry for your connection issues, but we're going to go now to our final presentation from MCGL. So I'm going to skip forward in the slide deck. John, go ahead. Over to you.
Okay, thanks very much, Nika, and all colleagues, and thanks for the presentation so far from Mali, South Sudan, and DR Congo. I think we've already gained some great insights. It's apologies for some of our technology issues. I does think it has interfered a little bit with our ability to fully engage in what's a really important topic. And I'm going to introduce the MCGL presentation, and then I'll take up moderating our Q&A after the final presentation. So as Anaclet noted, many countries are not on track to achieve the overarching under 5 mortality target under the SDGs. And many of those countries are in West and Central Africa, and also in countries that have experienced chronic conflict. There are various levels of fragility and the fraction of populations that are vulnerable, both across countries, but also within countries. And so we talk about fragile settings and more development stable settings, but there's really a continuum across all that. And both the Momentum Integrated Health Resilience Project and Momentum Country and Global Leadership, it's not necessarily a clean break between who's trying to help, which project is serving which populations. But we have to keep in mind that there are fragile populations, there are vulnerable populations in every country. We do know that for children that end up in primary and referral level facilities, particularly referral level facilities, the quality of care is a really critical determinant of mortality outcomes. And understanding why these children are dying is critically important to quality of care. And as Annika noted in his opening remarks, this issue of quality as a determinant of an outcome is a critical issue that we're all trying to address. And with general recognition that the quality of care is as important as just as effective access to care. We know that there are other factors that go beyond facilities in determining these outcomes, such as delays in care seeking in the first place or delays in referral. And we also have not acknowledged that in some settings, particularly some of the high mortality settings, a substantial fraction of child deaths are taking place completely outside of health facilities. For Momentum Country and Global Leadership, we engage with a number of countries on broad quality of care issues and with a focus on quality improvement processes, and increasingly child health and pediatric quality of care is an important component of those activities. And as we move forward, we are looking to work with those countries and looking at in the role that we play in helping countries both utilize global guidance, but also provide feedback on global guidance. How do they use PDA as a tool of improving quality of care? So to that end, we engaged a consultancy team from Oxford University to interview key stakeholders in several of these countries in which we're working. That's in Kenya, Zambia, Nigeria, and Sierra Leone, to really assess the state of play and offer some recommendations for how we might move forward. And so we're not presenting any results in these countries, but presenting the summary of what we've learned so far from these consultations. And I'm going to turn the floor over to Dr. Abdulaziz Imam. He was introduced earlier by Nika, and he's going to present the results, and I'm going to come back for some discussion of all the work, everything that's been presented today. So over to you, Abdul.
Yeah, thanks, John. I hope you can hear me clearly.
Yes, it's good.
Oh, thank you. So today I'll just be presenting some of the findings of the project John introduced to you. So what we did was look through the literature, but then, as John mentioned, we engaged with global and country teams within each of these three countries, so Nigeria, Zambia, and Kenya. And the idea was, one, to learn about MPDSR, so maternal and perinatal death surveillance and response. But then it was also to see where each of these countries were at in their journey for implementing PDA. And then the last box there you see is sort of to give initial options for implementations of for PDA within the context of MPDSR and also the quality improvement strategies. Next slide, Nika. So over the next set of slides, what I want to do is walk you through each of the three countries. One, the learning from MPDSR, but then also two, where the country is on its PDA journey. So the slide you see here is for Nigeria. When it comes to MPDSR, the Federal Ministry of Health has a dedicated budget line for MPDSR. But from some of our learnings, what we hear is it's occasionally being repurposed, particularly in the light of the COVID pandemic and all. Also, there is a bill that has passed through the House for MPDSR and audits and PDA. This is currently awaiting signing by the president into law. I heard about, I listened to Nicolas' presentation, and he spoke about digitization. So one thing Nigeria has also done is they do have an electronic data capture that has been developed, but then there's still some challenges with the electronic data capture. Nigeria as a whole has the structure of the committees. There's coordination between MPDSR and quality of care nationally. When it comes to PDA, there is a policy, government policy for all reproductive, maternal, child, and adolescent health to be under one umbrella. And so it's MPCDSR, maternal, perinatal, child, death surveillance and response. Although what we're seeing is despite the integration at subnational level, there's variable integration, but then at national level, it's quite integrated. And then the C component, the child component, is also in the bill that was submitted. Facilities do pediatric mortality meetings, but then it's not linked to the quality improvement process. Next slide. In Kenya, learnings from MPDSR show that government funds some of the activity, but then there's some donor funding through bilateral and multilateral agreements. At a structural level, MPDSR and quality of care are separate at committee level in Kenya, and then there's no legal framework. When we looked at PDA compared to Nigeria, which had started to integrate PDA into MPDSR, in Kenya, PDA is still in early stages of development, and so the government has commenced pre-testing and validation of WHO tools locally. But there's also a plan to report for PDA to be reported separately from MPDSR, and there's also a discussion for the perinatal component of MPDSR to be combined with PDA. Next slide. When we look at Zambia, for MPDSR, there's a strong political will to reduce maternal deaths. And I think this stems from MDGs and also the Sustainable Development Goals. There's also a strong community linkage with volunteers. And then quality of care and MPDSR are also separate in terms of committee in Zambia, and Zambia also doesn't have a legal framework. Of the three countries we looked at, PDA is one of the PDA it's not being used formally by the government in Zambia, although it's an area of interest of the Ministry of Health. There are no formal plans currently, and then PDA is used in some programs outside of government settings, for example, HIV and TB program. Next slide. So if you think about the health system on three levels, so the macro level, which is the broad health system, the meso level, which is the subnational level, and then the micro, which is within facilities. What we're seeing are some common themes emerging from our study of MPDSR. One has Demba mentioned, there are well-established committees across all levels, and they have their terms of reference. The challenge we see is funding, and then there's significant donor dependence. And because there's donor dependence, what we're seeing is different subnational implementation of PDA, and this is linked to how much funders are invested at that level of PDA. What we're also seeing is across board, and like Demba and other speakers spoke about this, is what we're seeing is there's a weak response in MPDSR. So MPDSR is more of the surveillance bits are strong, but then the response arm is weak. And this is linked to, one, lack of funding, but then the intersectoral nature of modifiable factors. For example, roads are linked to health, but then roads are not under the purview of the Ministry of Health. When we come to meso level, we see some selective reporting. And so this is the idea of the silent perinatal component of MPDSR in Zambia and Kenya, where you hear more about the maternal deaths, but few about perinatal mortality. And then at facility level, there's variable autonomy and budgetary constraints. At the micro level, which is on the front line, there's a limited capacity and culture shift. And so audits are not integrated with quality of care, and staff tend to view audits as extra work. Next slide. So we spoke to two, if you like, exemplar countries, South Africa and then Sierra Leone. The South African PDA program is more of the exemplar model, which has been there for 17 years. The Sierra Leonean program has been there for two to 3 years. What we see is both programs are bottom-up approaches, which started at the facility. And so the idea is use data for local level change at the facility, and then aggregate data as you go up at higher levels of administration. And then the greatest impact is at facility level. Next slide. So putting all this together, we looked at what are the options for country support. And there are some assumptions here. One, unlike MPDSR, probably the focus of PDA might not be surveillance, but then surveillance mixed with response, effective response. And then also, we're not routinely extending PDA to the household and communities. And then PDA should span early newborn to adolescents. And then improving quality of care is a major need. Next slide. So if you walk from left to right, the first column is the desired objective, and then the purpose we intend for what we suggest, the target system, and then resources we think we might need for support, and then time scales. For time scales, short is 1 to 3 years, medium is 3 to 5 years, and then long is 5+ years. If we implement PDA similarly to MPDSR, and so we have national reports on mortality with PDA being run in facilities, and then we have that reporting back to the center and response. So the purpose here might be, for example, to say, can we address facility care challenges at a scale? The target will be national, district, and facility. The idea here is, if that is the intention, then resources will be very high. We need multiple skill sets and stakeholders. And then time scale for such an implementation program will be long, so 5+ years. In the next set of slides, I want to show you 4 proposed options for countries. The first is, if you like, a soft target. If we say, let's have legal protections to support PDA, the idea is enable high-level culture change. So we're targeting national level. The resources are small to moderate. And then if politics is favorable, this is a short-term option. Next slide. Another option might be, let's pick a sample that is representative of a country. So, and we do facility-based PDA within this sample. The idea here might be catalytic, for example. So let's have a set of have a set of data that can function for advocacy and inform strategy and policy. And the targets are the 3 levels. Resources here are moderate. Depending on how much data we want to generate, it might be short to medium time scale. Next slide. This is, if we want to consider a bottom-up approach where our target is highly functional audit or quality of care demonstration at district level. So this is the subnational level. And the idea here is, can we show benefits or learn what is needed within the context we are doing it in, with the idea of possibly integrating this into the wider context. So the target here is the district. We need small to moderate resources, technical support, local resources. And then the time scale will be medium to establish a model, but then also to learn. The last part of this is, if we want our focus to be health workers, so inculcate a quality and safety mindset and skill. So this is pre-service. And the purpose here is the transformative agenda. The target here will be national and institutional level. And then we have, we need small to moderate resources. And then this will need a medium term. Next slide. So in summary, this is what we've proposed as options. of a possible way to implement PDA in our settings. Next slide. Thank you for listening, and I'll hand you over to John for Q&A. Thank you.
Okay, well, thanks very much, Abdul. I think that what you presented also builds on what we've heard in terms of some actual pilot country experiences previously from the other presenters, and lays out the full gamut of what needs attention and being realistic about what could be accomplished on relatively short to medium term timeframes, from supporting health workers directly to data systems, to legal and policy contexts. And I think one of my takeaways from all of this has been that we have to remind ourselves always that the central reason for undertaking pediatric death audits is not surveillance per se, although that's data gathering is a critical step as part of this, and that the key action is not simply ensuring that a policy context is appropriate, even if that may be a key enabling factor, but that we're actually trying to use this to actually take real action to improve outcomes. And we've thought that this could be done within the context of quality of care initiatives. And we've heard about the importance of integration into routine systems for data collection, the importance of changing a context for PDA from a blame game to actual improvement in outcomes and a collective responsibility for doing that. And we've also heard about the critical issue of governance as a backdrop for success. So we've got a couple of questions that have been coming up, and there's a first set of questions that are actually directed.
John, may I interrupt you? Because you asked in the chat if someone can be enabled. That can be done. If you let me know what the person is, Camilo can enable the mic.
Okay. So if we have about a little less than 20 minutes for discussion. If you wanted to come in and speak, please raise your hand and we'll be able to acknowledge that and open the mic for you. But there's been a few questions that have come into the chat. They've come in for Dr. Sasa first, so I'm going to put them out there, and I'll actually do them one at a time, or actually in two groups. So the first question was from Joseph Monahan from USAID, and the question is, apart from sex disaggregation, was the PDA data also disaggregated by age groups? And I guess I would just add on, given that the age range could actually be quite broad, but the challenges may be different in each age range. So Dr. Sasa, over to you. Is he there?
He's having some issues with his communication settings, so I'm not sure if he'll be able to open his mic.
He's in the
So
field right
someone
now,
else.
so he may have low connection, John, if you'd like to come back to him.
So can I go? Yeah, maybe
Yes.
I can jump on and try to respond to this question of John. Yes, South Sudan, they disaggregate all pediatric death according to the age group and sex and other demographic characteristics. But additionally to this, maybe I want to add that there is a specificity with PDA in South Sudan, because for them, they even go higher and audit up to 18 years. So they decided to, out of the audited pediatric cases, they add some few cases beyond 5 years. So that's something which is specific for South Sudan, but for sure they disaggregate also cases by age. Thank you. Over to you.
Okay, thank you for coming in, Anaclet. So there was a second question on South Sudan, and potentially this is also something that you might want to take up if Nicholas is not on the line. It was posed by Dilor Mitanta en français, so I'll do it in both ways. So the question was, au Soudan du Sud, en raison de la crise sécuritaire qui affecte le pays en ce moment et de la fuite de personnel qualifié pour des postes pour attrayant sur d'autres cieux, comment le pays envisage préserver les acquis actuels et promouvoir ainsi la résilience. So the question is, in South Sudan, due to the security crisis currently affecting the country and the flight of qualified personnel for more attractive positions elsewhere, how does the country plan to preserve current achievements and thus promote resilience? And this is, this is not an my editorial addition to that is that this is just not an uncommon consideration in many countries in this region. So, Anakle or Nick?
Yeah, do you want me to go with
Well,
English or French?
Nicholas seemed to be able to connect, so if he wants to come in
Okay.
first, then you
Okay.
can fill in if needed.
Is Nico?
Yes,
Yeah, okay.
for MIHR, actually, what we do is we engage partners who are directly involved in full-scale health services for the country. So our role is to advocate. So we don't have the capacity on maintaining those qualified health workers for health services. So what we do in most cases, those who are available, we provide trainings to them. So that's the most we can do. And we keep on advocating, trying to link them to partners who can support our major health projects.
We lost him, Anaclet. He comes in and out.
So, Anaclet, maybe you want to jump in to wrap up?
Hello?
Oh, you're back. You're back. Good. Please go ahead.
Yeah, and also one of the approaches, the Minister of Health, because of all these challenges, so the focus.
Nicholas, you're cutting out, so perhaps John, will you move to the next question? And Nicholas, if you could add the rest of your response in the chat.
Okay, that sounds good. And then, Anaclet, did you have anything to add before I move on?
What I was about to add is that for South Sudan, there are 2 points to mention. First of all, is the engagement of the pediatric South Sudanese Pediatric Association. They are really highly involved in this process, and this to me this is a key concept, because it allows really a kind of ownership, because they seem to own this. The South Sudanese Pediatric Association is highly involved, and this can allow really a kind of there's a commitment, and it can really guarantee some kind of the sustainability. Number two is that what Nicholas was talking about is about engaging all partners who are there, trying to ensure that all are involved. So otherwise, the staff turnover will be there. But the key thing is to ensure that once all people are there, they are all involved. If there is someone going, all the other one coming in, so that he or she will see things up and running, so that there can be some kind of the sustainability of the process. Over to you.
So thanks, Anaclet. I think my main takeaway from what you said is that it sounds like if we have the system well established, then the people may move, but the system will still work. And so I think that systems approach is actually quite critical. There's another question in the chat. This is another one from Joseph Monahan, and this goes to you, Abdul. But I'm gonna pose the specific question that he puts out there, which is: do you think the use of a legal framework as done by Nigeria is an approach that should be adopted by other countries, and has it made a difference in the rollout of that comprehensive MPCDSR in Nigeria? And I guess for the broader panel, having listened to all the presentations, if you'd like to respond to what seems to be the best in terms of actually effectively rolling out pediatric death audits on not only a sustainable basis, but on as a process, as an approach on which effective action can be taken. How important is a top-down approach in terms of having a legal framework and trying to push it out, versus having a bottom-up approach in which the focus is on facilities initially? So I'm going to turn it first over to you, Abdul, and then all the other panelists to come in as they wish to.
Thanks, John. So to answer that is, the short answer is no, but then to expand on that is, what we're seeing, particularly having spoken to Nigeria, Zambia, and Kenya, is different countries are at different levels when it comes to their journeys for implementing MPDSR, but also implementing PDA. If you notice from part of the presentation, what we see in Nigeria is formation of MPCDSR, so putting PDA within the context of MPDSR. But then if you look at Kenya and Zambia, the idea is to split the perinatal component because it's not working for them and combine it with PDA. I guess where I'm getting to is looking at this issue holistically, where I don't think there's a single magic bullet to say, this is what we're going to do prescriptive across countries. Within some context, top down might work, bottom up might work. What I'll say is, learning from MPDSR, what we're seeing is top down has challenges. We're not permeating the bottom. But then I spoke about Sierra Leone as a country that has used PDA for 2 to 3 years. Sierra Leone started from the bottom, but then they haven't been able to take it to the top. And the reason why is they don't have enough human resources at
Could you repeat that country for the translation in French? What was that country?
Sierra Leone. So I use Sierra Leone as an example. Sierra Leone started PDA for 2 to 3 years. They started at the bottom, but then it has arrested at the bottom because they don't have the human resources to take it to the top. I think the message here is, no matter where we start, top or bottom, it needs to be individualized to countries. And then there needs to be a system-wide approach of ensuring it permeates through the levels. Yeah. Thank you.
Okay, thanks so much, Abdul. Ido, I think you wanted to come in.
Oui.
Can I? Okay.
Merci
I see a
beaucoup.
hand
Je
raised.
voulais aussi appuyer l'idée parce que nous avons opté pour l'approche.
Yeah, we have an idea. We look for the bottom up in RDC. We thought that the process, the bottom up is more effective. We do, in our experience, but this is based on based on local experience, of course, and best practices that trickle up that can easily evolve. That's what I wanted to contribute to John's, your reading of the question. To that key question, so our take is bottom up.
Yeah, please, Annika, you're next, please.
Yes. In my experience, first of all, at the beginning, we said that PDA is a quality of care tool. So if we agree that PDA is a quality of care tool, normally the RIGO framework should not be a big issue. But what I know is that where we have the RIGO framework, or we have sometimes the ministerial instructions instructing the MPDSR or PDA, normally they want to focus on surveillance. They want to look at they want to ensure that each case is really it is notified and we said it is audited. But in most of the time, the real PDA or the real MPDSR is when the health facilities themselves, they sit together to go deeper and really discuss what happened. So the legal framework normally can be there to guarantee that the findings from PDA and MPDSR will not be used to traduce people into court. That can help. But normally, people may not even have the legal framework when they sit together and then consider PDA and MPDSR as quality of care tool, and then go to step 5 to put into practice or do action. actionable points to improve the quality of care. So it depends upon the country, but normally countries may not have it or may have it. Over to you.
Okay, thanks. So just to summarize the point is that you don't need a legal framework to take action at a facility level, but a legal framework can actually be, it's just to a degree, reassuring that that taking action and recognizing a problem is not going to create any legal challenges. Okay, so I'm going to go over to Demba. You wanted to come in, please. Demba, the floor is open to you.
Tu peux ouvrir ton micro, Demba, tu peux parler, ton micro est attendu, il faut l'ouvrir, le micro.
Je peux
Voilà.
parler?
Oui, voilà.
Je peux?
Oui, tu peux parler.
Ok, merci. Donc moi, je
Thank
voulais...
you very much. I would like to contribute to the discussion about the process of to this process with the experience that I have on the ground, on the terrain, and in management. There are two important levels to address John's question. I mean, to achieve effective results. The first level of the audits is the commitment and the decisions of health professionals, because they are the ones that are going to carry out these audits. Without that commitment and expertise, without this analysis, we cannot know what are the real causes of deaths. And once these modifiable factors, we can create a plan, and we delve into action and responses, and to trickle down to the public health program. They're the ones that manage these public health managers. They're the ones that occupy themselves in following up the deployment of the plan to be able to obtain a positive change of pediatric mortality reduction. These two levels, if these two levels don't collaborate, without these two levels collaborating, and while the favorable environment for caregivers is present, without that, it's difficult to have positive outcomes and results. As we've said, these pediatric deaths is their ultimate end, and they depend on quality of care, effective quality of care improvement, and it goes through the commitment of improvement in programs and the decision of partners and suppliers to improve lack of services and lack of access. That's my take, John. Thank you very much.
Okay, thanks very much. So there's another question. There's a comment and question in the chat from Nancy Harris, and I'm going to, with apologies to Nancy, actually interpret it a bit. So her comment was, we are very early in the process in general of applying PDA, and yet it's not necessarily pointing us in a direction that this is going to be the most useful tool in improving quality of care, or we're not seeing that evidence at this point. I guess I'd have to say it's also a little bit early, but let's think about that a little bit more. And what do we think? And this is a question I'm going to interpret then for all, interpret and put out there for all panelists. What do we think that PDA is going to, in the end, be a useful tool in improving quality of care for children in facilities, and ultimately in reducing mortality, in the same way that we've seen maternal death audits become a useful tool in improving maternal health outcomes, particularly institutional MMR? Or should we actually just focus on some of the things that we already know need to be done to improve child health outcomes? So I would add on that's an interpretation of Nancy's question. I hope I've done it justice. But then I would also add on, as we've talked about, for example, in the presentations, the identification of modifiable factors. To what degree is pediatric death audit necessary to understand which things need to be addressed, and to what extent do we already know what those things are? So I'm going to turn it open to the panel, and the first person up is Anakle.
I think we are running out of time, but I will try just in a few seconds.
Because you had your hand
yeah.
up, Anakle.
I just attended the one PDA session in South Sudan and see how people were really engaged and committed.
So I'm hearing nothing.
You don't hear me? Do you hear me?
Is anybody else interested in coming in on this question?
I hear Anaclet. Go ahead, Anaclet.
I see you've turned your mic on. Do you want to come in?
No,
yes,
I can hear Anaclet.
Anaclet is on.
Yes.
Oh.
Okay. Yes.
Okay.
I was saying that when I attended.
Please just go ahead, Anaclet. I won't know what you're saying.
Okay. I said that when I was attending the PDA session in South Sudan recently, and see how people were discussing really on what they can do. There are always some measures and actions they take, even at the health facility level. I remember they are saying, what we are seeing that these intern doctors, they don't know how to provide the emergent care to under 5. Example is severe dehydration. So they said let's first of all make sure that we train these intern doctors on day 1 before they start, and then they take such kind of actions. And by the end of the day, all these kind of actions coming out based on the PDA findings, they can really change things and then really save some lives, even those actions taken at health facility level. Yeah, that's what I can say. Thank you.
Thank you, Anaclet. So I know that we're running very short on time, so we want to make sure that we have adequate time to wrap up.
Okay, thanks. I think unfortunately we're at time. So Nika, I'm not sure if I'm having a problem with my audio. I'm not hearing everything. I'm just going to turn it back over to you to wrap up with Nefra. Thanks.
All right, thank you so much. And thank you again for these thoughtful questions and answers. We wish we had more time to go through them, but certainly invite our panelists to add more to the chat if needed. Before we close out, I'd like to invite our colleague Nefra to share some final thoughts. She is a Senior Child Health and Immunization Advisor in the Bureau for Global Health's Office of Maternal and Child Health and Nutrition, Child Health and Immunization Division at USAID, with nearly 17 years of combined clinical, preclinical research, and global health programming and policy experience in the public and private sectors and in more than 30 countries. So Nefra, I'm gonna turn it over to you just for some closing thoughts.
Thank you so much, Nika, and sincere thanks to all of our fantastic presenters from today. Un grand merci à tous nos présentateurs estimés d'aujourd'hui. Nous avons
Thank you very much to all of you. Thank you very much to you for your contributions.
As you heard throughout today's webinar, after decades of remarkable progress, the rate of decline in under 5 mortality has slowed in many countries. And based on current trends, 54 countries are currently off track towards reaching the Sustainable Development 3.2 goal of reaching under 5 mortality and reducing it to 25 or fewer deaths per 1,000 live births by 2030. Most of these countries are in Africa, and a large number of countries are considered fragile or conflict affected, including many that you've heard from today, where we also find some of the world's highest under 5 mortality rates, and where deaths among children ages 1 to 59 months old account for the majority of under 5 deaths. And this is a starting point for Child Survival Action, a global initiative that hopefully many of you have heard about, that includes a coalition of partners like WHO, UNICEF, the Global Financing Facility and World Bank, USAID, of course, Save the Children, and others, under the coordination of the Child Health Task Force Secretariat to accelerate actions to reduce mortality among children under 5, especially where this progress is lacking. CSA works alongside Ending Preventable Maternal Mortality and the Every Newborn Action Plan initiatives as well to address preventable child and maternal deaths, which is, of course, a critical priority for USAID. And all 3 of these initiatives share the same goal of ending preventable deaths through a life course and continuum of care approach. And they all emphasize the importance of quality of care. Equity is also a key implicit principle when it comes to both MPDSR and PDA to ensure that no one is left behind in our collective efforts, first to find and then to prevent future preventable deaths. And all presenters today reminded us that inequities in under 5 mortality are driven by many things: differences in access to care and preventive services, differences in the coverage of essential primary healthcare services, and poor quality of care. And then compounding these challenges is that in fragile settings in particular, we often see children with multiple deprivations. MIHR's child health lead, Anaclet Ngambonzima, called on us to remember 2 key messages. First, that quality of care for newborns and children and determinants of health are critical to reducing preventable child deaths. And second, and related, that PDA should be considered a quality of care tool because understanding modifiable factors that contribute to child deaths can help us learn how to make systems improvements from the household to community to facility levels and beyond that can prevent future deaths. Common to MIHR supported PDA introduction in Mali, DRC, and South Sudan, we heard, was using MPDSR as a platform and entry point for that PDA introduction. In Mali, as we heard from Dr. Traore, this began with a national MPDSR adaptation workshop, piloting and digitization of tools, and the formation of clinical audit committees. From Dr. Balunto in the DRC, we learned that having MPDSR committees already in place was an important enabling factor in providing a platform for and readily integrating MPDSR. And then in South Sudan, from Dr. Sasa, we learned about the importance of local partnerships with those like Al Sabah Children's Hospital and the South Sudan Pediatric Association, and of integration, including when it comes to training, to introduce and strengthen both MPDSR and PDA. We then heard from Drs. John Barrazo and Abdulaziz on key informant interviews they conducted to try and understand how mortality audit, quality monitoring, and quality improvement could be integrated to optimize effectiveness in low and middle income countries, including when it comes to pediatric death audits or PDA. Dr. Abdulaziz highlighted some common themes in learning from both MPDSR and PDA rollout to date, like the importance of having well-established committees with terms of reference, and the importance of having legal frameworks in place, the challenges around funding and significant donor dependence, which has contributed to differential subnational implementation. The fact that we often find that the surveillance piece is strong, but that the response piece is weak, again, also linked to funding, and that we can also often find incomplete and selective reporting. Dr. Abdulaziz also noted the importance of limited technical capacity and the need for cultural shifts to integrate MPDSR and PDA as part of routine quality improvement and quality of care cycle efforts. We need a renewed focus on and commitment to strengthening the unfinished child survival agendas to reach our SDG goals. And definitely what this means is supporting health systems and scaling interventions like quality integrated management of childhood illnesses at the community and facility levels, strengthening referral systems and improving quality improvement and quality of care in both the public and private sectors. Pediatric death audits play a very important role, to be sure, in this ecosystem. So with that, perhaps I'll steal a note from one of Dr. Barrazo's earlier comments, which is that the point of all this is not surveillance in itself, but really to take action to affect real outcomes. Thank you all for your commitment to those shared real outcomes of reducing preventable child deaths. We really look forward to tracking the work supported by both MIHR and MCGL in their continued efforts to both introduce and scale up pediatric death audits in their partner countries. And we hope to hear from them again, perhaps several months down the line. Thanks again to all.
Thanks so much, Nafra. That was a wonderful summary of the presentation today, and I think gives us some things to look forward to for the future coming from both of these projects and across our partners as well. So thank you all. With that, we just want to show a few upcoming Momentum Integrated Health Resilience webinars on the horizon that we encourage you to attend. They will be shared to our website, linked below. Recordings from today's session will be posted to our YouTube page shortly. And yeah, with that, we just would love to thank our panelists for joining us. We know you are working very hard in your respective regions and joining us from different time zones and different internet connections. So your participation and thoughtful presentations today are so appreciated. And thank you to our audience for joining. We look forward to the next webinar and hope everyone has a good rest of their day. Thank you.
Thank you. Bye.
Thanks, everyone. Bye.
Nika, if you can stay behind just a few seconds.
Yep, that sounds good. You can stop the recording.
Thank you all.
Thank you. Bye.
Merci. Merci beaucoup.
Merci à tous.
Merci, merci. Merci à tous.